So my name is Pam Valentine. I'm the Chief Operating Officer at Alberta Innovates Health Solutions, and I'm delighted to welcome you on behalf of Alberta Innovates Health Solutions and the Institute of Health Economics to the fifth event in our joint health policy speaker series. Before I introduce our distinguished guest and speaker, I do want to give a warm welcome to some special guests. Dr. Abby Angel, President, Friends of CIHR, which established the Henry Friesen International Prize in Health Research. Dr. Henry Friesen, the former President of the Medical Research Council, now CIHR. Susan Anderson, the Assistant Deputy Minister of our Health Information Technology and Systems Division at Alberta Health. And Christine Couture, I also noticed, is in the audience. And our President and CEO, Dr. Cy Frank. I also want to welcome the board chair of the Institute of Health Economics, Dr. Lauren Terrell. We're pleased to have so many representatives from different sectors in the room today. It speaks to the importance of the topic that our distinguished guest speaker, Dr. Harvey Fineberg, will speak to us about today. AIHS is proud to be able to help sponsoring Dr. Fineberg's visit to Alberta. Dr. Fineberg is the 2013 Henry Friesen International Prize in Health Research winner. He's the president of the Institute of Medicine at the National Academy of Sciences. He has served as provost at Harvard University and the dean of Harvard School of Public Health. The fields of medical decision-making and health policy to which Dr. Fineberg has contributed enormously are areas that are of critical importance to the citizens of our province. Creating an integrated system in Alberta that brings health research, the health system, and health policy development into closer interaction has tremendous potential. And we're very pleased and honored to have the opportunity to share in Dr. Fineberg's expertise in understanding how medical decisions are made and health policies are formulated to ensure that evidence and knowledge that research produces will be put into action. So I'll ask you to join me in welcoming Dr. Harvey Fineberg to the podium.
Good morning, everyone. It's truly a pleasure for me to be here, and Pamela, thank you so much for that very generous introduction. I am delighted to have this opportunity to speak with you for many reasons. It is truly an honor to represent the Henry G. Friesen Prize as this year's winner in the way that Dr. Angel has organized the program through this year. I've had the opportunity to visit a number of cities in different provinces of Canada. And so it's been a pleasure for me and also a great learning experience for which I'm very grateful. And it's also provided me a personal opportunity to become acquainted with one of the true luminaries in health science and leadership in health, Henry Friesen, who has been not only a great leader for Canada, but set a standard for sensible guidance of health science for any country in the world. And it's been a wonderful privilege to interact with you, Henry, over the course of these months that I've had the privilege of bearing the Henry G. Friesen Prize label. And this day is a special day for me because I also have an opportunity to see some very dear old friends. I should say friends of long standing, Egon. I think it's a much better way for those of us at a certain stage of life to express it. But Egon and I intersected at the Harvard School of Public Health. I won't say exactly how many years ago, but it was before some of you found your way onto the planet. So it's a pleasure, Egon, to see you here and to have a chance to interact with all of you. And I truly do hope this will be an interactive opportunity, a chance for dialogue. I say that because not that I think there are no good ideas from the US or that I can bring that might be of interest, but because I am convinced that no nation, not Canada, certainly not the United States, really not any, has fully come to grips and solved the core dilemma of health and health care. And the core dilemma, keeping a population healthy, establishing a successful and a sustainable healthcare delivery system. How do we manage those tricks? And they are very, very demanding. I want to talk specifically about the areas of safety in healthcare, about quality of care, and about elevating value in healthcare, which introduces the component of cost, which is at the core of economic analysis for health. In Canada, of course, you begin with a foundation in which you have established the principle that every citizen, every resident, has an entitlement to access to health care, core health coverage. And in Alberta, you have made it possible for everyone, regardless of their economic circumstance, to gain access in the same way to health care. This is a tremendous achievement, and it's especially attractive from the vantage point of someone south of the border who is in a country where we have not managed over many, many decades of effort to accomplish a similar level of access, coverage, and availability of health care for every citizen, much less every resident. But that's only a foundation. It's a beginning. It's a necessary, but it's not really a sufficient condition to accomplish the goals of making health care actually delivered where it is needed, to whom it is needed, when it is needed, and in a way that is not wasteful of resources and that enables people to live their lives to the fullest and enables everyone who is supporting and contributing to do their part without breaking the bank. Now, in the United States, we set the pace in one dimension of health, and that certainly is the cost of care. So you could comfort yourselves in Canada very readily to say, well, we're not nearly as expensive as the United States. We're not spending nearly so much as the United States. I would submit that that's rather cold comfort. That in fact, every society is facing tremendous demands for health that outpace its ability over time to supply the resources that will meet those needs. And this raises a core challenge that I want to come back to, which is how do you align the available resources and make them serve the needs of people in the way that will most advance their health? Very, very core, very critical. Now, at the Institute of Medicine, where I'm based, a decade ago, we produced a pair of studies, one of which was called To Err is Human, and the other of which was called Crossing the Quality Chasm in Healthcare. These two reports really set a standard around thinking about the problems, the twin related problems of safety and quality in healthcare. The essential message looking at the problem of safety, and in the United States, our estimate was that every year, tens of thousands of patients died because of errors in the course of their care. Now, I would ask you, a very knowledgeable audience, how many of you have a relative or close friend that you believe had an experience as an error in the course of their care? Anyone? More than half. I would say that this is the experience that you have almost everywhere that we ask. And when you have a health system that produces a certain number of errors, what the Institute of Medicine Committee said is that the way to understand it and the way to deal with it is not to berate the individual providers, not to think that we just have to get people to try harder, Rather, it's to understand the systems and processes of care that lead to those errors and correct them. Lots of lessons from other industries, particularly from the aviation industry. You know, in the 1930s, getting on even the first Dash airplanes was a life-risking enterprise. Today, by and large, air travel is the safest means per passenger mile to get anywhere in the world. How did that happen? Not by chance, not by mere experience, but by converting flying into a systematic, absolutely routinized system. I tell the story about the JetBlue aircraft that was flying into San Francisco, and the nose wheel of the aircraft was turned 90 degrees to true. So the pilot was told by the tower the nose wheel is not in the right orientation. So they raised the gear and lowered the gear and raised the gear and lowered the gear. It didn't change. They flew out over the Pacific and they began dumping fuel, and the airport began to prepare for an emergency landing. Now, I don't know if you've ever flown JetBlue, but JetBlue has a wonderful feature, which is they actually receive and transmit to every seat on the video real-time television. So everyone on the plane is watching the newscast of the video showing their nose turned in the wrong direction. Now that's what we call a postmodern experience. So the plane made its final approach. The airport was cleared out on the landing strip. The pilot landed the plane perfectly on the rear two wheels and feathered the plane as it was gradually stopping until the nose wheel touched the tarmac. It began to smoke, it began to flame, and then the plane simply came to a stop, and everyone said that was the smoothest landing they had experienced. Why do I tell that story? Because the pilot, Scott Burke, I can assure you, is a very skillful pilot. But I can also guarantee that every time before he takes a plane up, before this incident and after this incident, he checks through the checklist of pre-flight clearance in exactly the same way every time, no matter how excellent he is. It's not a matter that he's a great expert in flying and therefore doesn't have to go through the exact same checklist. And so checklists have also become more and more a standard in surgery, because no matter how skillful a surgeon you are, no matter how well you could land that patient, the same checklist applies. And those institutions and practices that have adopted systematic systems approaches and clear processes about improving the safety of care have made remarkable progress. So that in many institutions in the United States today, the incidence, for example, of central line infection in intensive care is 0. Not 1 per 1,000, not 1 per 5,000, 0. That's the right number of errors. And if you have a system of care in your intensive care unit where you have 1 in 500 or 1 in 1,000 or 1 in 5,000 central line infections, the engineers would tell you that's because you have designed your system exactly to produce 1 in 500, 1 in 1,000, or 1 in 5,000 errors. Your system delivers exactly the results that it's designed to deliver. And if you want to deliver 0 errors, you have to redesign your systems to assure that there are 0 errors. So safety, as a core part of healthcare, is going to be something that we need continued attention to, regardless of the fact we have or have not yet solved the access problem for every patient. Now, in the report on quality, the Institute of Medicine articulated 6 dimensions of quality. It said safety was the first, but effectiveness was the second. And it said care that is high quality is patient-centered, and it's timely. And it said care is efficient, and it has to be equitable, those 6 dimensions, if it's going to be of high quality. So safety was included, but I think the core of the quality idea is patient-centered care. Because if you have the needs of the patient first and foremost in mind, all of the other attributes tend to follow from that. And this is something that is very crucial in the relationship of the caregiver and the patient, and it is a feature of a relationship and expectations as much as it is an aspect of training and of preparation of doctors. Sometimes when we think about medicine and the role of doctors, we think about different styles of practice. There's the authoritarian style of practice. You've seen doctors, maybe you have a doctor like this. Here's your problem, here's what you do. If you don't like it, find another doctor. We knew a lot like that at one time. A second style of practice is what I would describe as another, if you will, postmodern attribute, which is essentially you have a problem. There is lots of literature about the problem and what to do about it. I've given your husband a stack of reprints for the 2 of you to take home. When you decide what you would like, let me know and we'll proceed. That's turning over the responsibility to the patient. Now, the third, which has become the guide, is, of course, shared decision-making and partnering in decision-making. And the logic of this is very compelling because, in principle, the expert physician has the knowledge and the awareness of what the likely consequences are of the disease and the condition. But you, as the patient, have the knowledge about what you would prefer and what really concerns you and what you would like to see in your own future. And so the ideal of partnership is to try to bring those 2 together in a systematic way. But what I would like to suggest is that there's a 4th way, which is, I think, more true to patient-centered care, and that is the adaptive care that tunes the relationship to the needs of that particular patient at that particular time. There's a wonderful article that was written by Franz Ingelfinger, the legendary editor of the New England Journal of Medicine, a gastroenterologist specialist. It was published posthumously. The title of the article is Arrogance. In this article, Franz Ingelfinger describes his own experience with his own illness, which ironically was cancer of the esophagus. This was a topic that he had studied. He was one of the world's experts. He knew more about it than most any living physician, much less anyone on the planet. And what he says in this article is how he came to a point in his care where he knew there were a number of choices: surgery, chemotherapy, what to do, in what order, what sequence. And a friend of his said, "You know, Franz, what you need is a doctor." And what his friend meant by that is he needed someone to take the responsibility to make the decisions and tell him what he needed to have done. And the fact of the matter is, at different stages of life and different people and different temperaments, they have different needs as to what they expect and require from their caregiver. And so I think the truly patient-centered system is a system where the caregiver attunes their style to the needs of the patient and doesn't force the patient into their expectation of the relationship, even if it's a shared expectation. So patient-centered care is going to be a real challenge because it requires, over time, a change in the culture of healthcare, the culture and sense and meaning of professionalism, and the ways in which physicians particularly, but also nurses and other caregivers, will relate to patients and meet their needs. Now, I want to talk also about the value proposition in healthcare, and this gets to the issue of costs. Every society has to deal with the balance of demand for healthcare and availability of resources. In general, when you have a service that people value and desire, you're going to have more demand than you have the capacity to provide. How do you reconcile the excess of demand against the availability of resources? In the United States, we have a particularly unsavory method, which is we don't insure 40 or 50 million people. So we exclude them from the system. That's a form of reconciliation of demand to supply. Or you could use the word rationing, if you wished, in economic sense. What about Canada, where everyone has access to care? In Canada, you ration by the timeliness of the service and the availability of the care. And so if you want someone to be able to get the MRI for their knee or hip in 4 days instead of 4 months, you have a challenge in thinking that through. And Abby Angel and I talked to a driver on the way to an airport who told us he had to wait 4 months for his MRI. So if you want to change that to 4 days, that's going to have to come somehow in reconciling demand against the availability and willingness of supply. Same is true in every country in different methods. So there's no escaping the need to reconcile. I like that version of the R word rather than ration, because rationing scares people. But to an economist, it's a neutral term. To most human beings, it's a dangerous word. So let's just talk about reconciling. So what do we do? In the case of healthcare, you have a number of tools that are at your disposal that can help improve value in healthcare and align the needs with the available resources. Of course, you can say we want to provide more services, but that means an added cost. And you can ask yourself, well, of the services we're now providing, are 100% necessary medically and desired, or are they simply demanded? And if there's a difference, why? Now, that's an empirical question, but I can tell you that one way to think about it is to think about the incentives that apply to every element in the system. The incentives to patients, the incentives to doctors, the incentives to institutions like hospitals that provide care. How do those incentives lead to a reconciliation or a distortion of the supply and the demand? Now, in the case of doctors, there are 3 bad ways to pay them. One is fee-for-service, one is capitation, and the other is salary. They're all bad. Why? Because they all introduce distortions of one kind or another in what you would ideally like, which is the doctor who's purely there designed to provide the care and only the care that that patient requires. The basic problem with fee-for-service, I know it may surprise you, so I'll say it slower. If you pay someone to do things, they will do more of those things. Do you want me to repeat that? You got it, okay. So fee-for-service has a built-in incentive to do more, provide more services. That doesn't mean provide ultimately the best health outcomes. That's a different proposition. It means provide more services. Now, you could say, what do you use to condition that incentive to provide the right services? And you might say, well, we rely on the professionalism of the doctor to make the right choices and not to do the wrong things. And that's a pretty good and important influence. But study after study after study has demonstrated that the doctors, as professional as other doctors who are paid fee for service, tend to do more of the things than the doctors equally professional who are not paid fee for service. Well, what about salary? Well, the difficulty with salary for independent practitioners is you've got to make sure they show up and do their job. So you need to have a system that's going to insist and reinforce the idea of providing the services that they're supposed to provide. And capitation is an invitation to do less than is needed, because you're going to be paid just the same if you do anything. So the cheapest thing for you as a provider is to not do things. So there, if you're going to have a capitation system, you've got to have measures and track quality and performance and make sure that standards are being met. So my point is, every way you might choose to pay doctors has built in a financial incentive, which is not determinative but is influential. And that you need then to design a system that is countervailing and compensates for the shortcomings, whichever they are, in the system that you have. In the US, there's a lot of experimentation now with alternatives to fee-for-service, and in package payments, and in bundling payments, and in encouraging prepayment. And these are going to be very important for the US over time to sort things out and move away from a preponderance of fee-for-service. Very interestingly, in the US, we have some circumstances where the physicians are actually employed and salaried, but the institution that's employing them is still billing on a fee-for-service basis. So this is a very interesting refinement of the question exactly what incentives to what organizations and what individuals. Now, what about the patients? What about the individual patients? Right now, as I understand it, in Alberta, care is free. There's no copayment. There's no deductible. You don't cover everything, as I understand. You don't cover in the public way pharmaceuticals, drugs. You may not cover certain rehabilitative or chronic care facilities, but you do cover the basic services without any copayment or deductible. And without copayment and deductible, philosophically, is a very important part of the principle of available care to many people. But it does mean there's no disciplining in any normal way of a market that would apply to individual patients. Some people would argue, that's fine, I don't want any disciplining. I don't think of this like automobiles, and if you all want to get a Lexus instead of a Honda Civic, you just line up and wait until the next Lexus is available. You might have to wait a while, but you'll get it instead of just taking a less expensive car that will get you from where you want to be to where you need to go. So you could say, well, it's not like automobiles. We feel differently about health care. But I would submit that it is, therefore, introducing a problem that you have to deal with about timeliness and availability of services. And you have a choice. How do we reconcile the availability of the resources we're prepared to invest collectively with the demand that's coming from patients? It turns out that markets are a marvelous and, if designed properly, pretty fair disciplining proposition. I just had the occasion before coming on this visit to have a brief trip to Cuba in the Caribbean, and it's a fascinating place. I know 1 million Canadians go there every year. Maybe many of you. How many of you have been to Cuba? probably to the beach directly, right? I mean, I understand the direct flights tend to go to those northern beaches. We spent a few days in Havana, and of course, the first thing you notice is all of the vintage automobiles. I want to have the auto import license as soon as the U.S. gets over this embargo stuff, because there's a fortune in vintage vehicles riding around Havana every day. However, set that aside for a moment. Of course, as a central economy, they have guided every economic decision. And it's obvious it doesn't work. It cannot work. It's just too complicated. And the disciplining of just allowing people with their own resources to decide what they want to buy and how is so much more efficient, and obviously has to be reconciled with inequities and make the system available. But what you see in Cuba is an economy that does not function. It simply doesn't function. So what does this have to do with the health care in Alberta? If you already have everything that's free for patients, is it possible to discipline and allow people to have economic interest? I would submit, if you wanted to, yes. The answer is, I think you could. Why? Because you could make care cheaper than free, or not. And what do I mean by that? Depending on your income, you might be able to get a tax rebate every year. And if you accept the tax rebate, you're going to have a health card which includes a deductible and a copay. And so you can get $1,000 a year for the family back, but it means you're going to accept a certain amount of copay and deductible in your care. And it could be your choice. You could keep it the way it is, or you could opt for the system with the copay and deductible. And I would predict there are lots of people who would rather see the $1,000 first and be willing to take their chances on the copay and deductible, and they will think twice about whether they actually do need what service at what point along the way. So it's imaginable if you wanted to do it. In the US, we've got a very different nature of the problem right now, because our system is so costly and so overextended in its expense that we have a truly urgent problem of reducing costs. But here's a strategy that I believe would apply equally to hospitals in Canada, as I think will apply to every hospital in the United States. And it's such a simple idea, and yet it does not often find its way completely into the management of hospital services. And hospitals are important because that's where a lot of the expense is actually taken up. And I'm talking about the ways in which we admit patients and flow patients through the hospitals today. You might think that admissions to hospitals are mostly erratic because of emergencies, that you can't tell when people are going to have an emergency, they come to the emergency room, and that is a source of irregularity in the flow of patients into the hospital. Well, there is irregularity because of emergencies that people have. And by the way, have you ever seen an emergency room that's not overcrowded sometime during the week? Most emergency rooms get overcrowded. It turns out in many, many US hospitals that have been studied that the problem is not the erratic arrival of patients in emergency. The problem is structured fluctuation in admissions because of doctor preferences. So the variability in the flow of patients into the hospital is greater in the planned admissions than in the emergent and unplanned admissions. And why is that? Well, most surgeons don't like to admit on Fridays to start with. And the reason they don't like to admit on Fridays and operate on Fridays is because they might have to be called back on Saturdays, which is not a good thing. And it means that when you start at the beginning of the week, by the time you get to the midweek, your emergency room is going to get backed up because the flow of patients into the hospital in midweek has burgeoned compared to what it is at the very end of the week and the management of it at the beginning of the week. It's usually tolerable on Monday because it's cleared out over the weekend, but by the time you get to Wednesday and Thursday, you've typically got a real backup in the emergency room. That's usually the day that the emergency administrator calls the hospital director down to look at the emergency room, which is overcrowded, and to make the case that we need to build a bigger emergency room. Why? Because we have to accommodate more people. They're sitting in the hall. And that's a little bit like, you have a rain barrel, and it's a big barrel, and it's overflowing with the water, and you say, well, what we need is a bigger barrel, and what you really need is a larger spigot emptying the barrel, because it's always going to overflow if you never let any water out, no matter how big it is. And so if you can persuade your surgeons to try and be willing to normalize the flow of admissions over the full course of the week, and thereby take better advantage of the capital expense of the hospital in operations, and you can set aside a single operating room for those emergency overflows, and you can get the doctors and the surgeons to regularize their procedures, you can work miracles on the flow of patients, in the availability of resources, and in the emptying of the emergency rooms. And a number of hospitals in the US have demonstrated remarkable changes, literally a doubling in the course of a year of the number of patients they can process out of their emergency services, an increase in the fraction of patients that are discharged to the correct nursing floor because they have regularized the flow, and the orthopedic patients get to the orthopedic nurses, which is better care for those patients. And this is something that can be done without a single dollar investment in capital. And indeed, Cincinnati Children's Hospital that introduced this estimated that it saved $100 million in capital investment in additional beds that it did not have to make because it was able to regularize the flow of patients through the hospital. So this is one technique that can really dramatically change the complexion of cost without in any way impairing and even while enhancing the quality of care. All you have to do is persuade the surgeons that it's worth trying to change. Now this brings me to the final point on change. Most people, when given a choice between changing or explaining why there's really no need to change, get busy on the explanation. How does one introduce the idea of change? And to do it in a way that's successful, to do it in a way that is agreeable, to do it in a way that's demonstrable for its effect, is really the greatest challenge to leadership in healthcare today. Whether you're in a ministry, or you're in an institution, or you're part of a profession, or you're in an educational setting, it's all about making the right change. And doing it in a way that is persuasive, that if it can be done in a testing and experimental way with the demonstration of evidence to make it more tolerable and more agreeable. But if we don't try to change and make it better, it will not get better on its own. That's our challenge. That's the challenge for safety, it's the challenge for quality, and it is certainly the challenge to increase the value in healthcare. Thank you all very much.
And thank you very much, Dr. Fineberg. I'm John Sproul from the Institute of Health Economics. And so we now have 15 minutes or 20 minutes for questions. So I'm sure there may be some comments from people. So you can put up their hand and I'll run around.
Thanks very much, Dr. Fineberg. Really enjoyed your talk. My name is Verna Yu, and I'm the CMO for Alberta Health Services. My question for you is around patient-centered care and the involvement of patients. And just wanted to get your view about how do we integrate the patients into every single level. We really appreciate your advice on that.
Thank you. You know, the roles of patients are actually at many levels, and I think we should be thinking about their roles in different ways. First, of course, the patient as an individual requiring care and needing care and their relationship to their caregivers. That's the first set of the role of the patient. But there's also patients as a group with a particular condition and their role in an institution in helping the institution to provide better care, and the role of patients as policy advocates and as influencers of policies about the nature of health care and the ways in which care can be delivered. So I think that when we think about the roles of patients, we need to establish the standards and the expectations and the means for the patient to play their role as the person, the individual getting care, as one of a group helping an institution improve its performance on quality and safety, and being a voice of the patient, so that it's not always the radiologists who have the parking spaces in the most convenient place. Maybe the patient advisory group would say, you know, there are handicapped patients who ought to have those spots, not the Department of Radiology. So you need to have a chance for those discussions to take place. And then patients as champions and advocates of policy that's broader, including, most importantly, research strategies, where the involvement of the lay public in the ideas and in the development of the research programs is also very, very important. So I think that patient-centeredness is much more than just the role of the patient with the individual provider. As important as that is, I would love to see us think about mechanisms at every one of these levels for engagement with the lay public and with individual patients. Thanks.
Any comments from? I have one quick one, because you'd focused quite a bit at the Institute of Medicine around more effective and efficient care delivery and dealing with the quality and safety. A lot of things I think we're trying to deal with too in Alberta is upstream influences on health, and also how you might deal with integration of the practice of medicine or healthcare delivery with connections with some of those other determinants and other things where you can assist in preventing people from having to access healthcare in the first place. And I don't know if you have any comments on some best practices or knowledge in that area.
Well, thank you very much for that important question. One of the tremendous advantages I think you have in Alberta is the fact that you have an integrated ministry responsibility for both the delivery of medical care and the protection of health of the public and the prevention of disease. And so you have built in the potential mechanisms to think broadly and in connected ways about personal health service and population health strategies that can prevent disease. Also, because it's a public responsibility, you have the opportunity to be thinking in the very long term. You do not have to produce quarterly results that get proven to a set of shareholders that you're making the difference. And so much that we do in prevention has long-term payoffs without very near-term effects. So if you are able to dissuade people from starting to smoke cigarettes, or you're able to enable more people to quit smoking cigarettes and all tobacco, we are very confident that over the course of 10 to 20 years, we will see a dramatic reduction in incidence of cancers of various types, particularly lung cancer and also heart disease and other conditions. But we won't see those in the first year. So being able to make those long-term trade-offs is a great advantage. Now you have, I understand, some new experiments with networks of primary care. Networking primary care is a great concept in terms of the relationship of caregivers to responsibilities for populations. But I would say, to me, the great challenge is how do you take the integrated responsibility at the level of a ministry and translate that down to the level of the delivery of preventive and caregiving services so that institutionally it's also integrated at an operational level, so that when a hospital is thinking about its responsibilities to patients with diabetes, it's also thinking about keeping people out of the hospital, not merely giving excellent care when patients are admitted to hospital. And so translating the principle into operational and responsible terms at every level is, I think, a very important part of a strategy to integrate prevention and the delivery of care in just the way that you're describing. And it's an opportunity that you have here in a way that very few other national or provincial or regional jurisdictions actually have. And I believe Alberta could be a model for this type of integration.
Any questions from? Okay, this one. I will run, because it's preventative for health.
Good morning. My name is Teresa Reardon. I'm Executive Director for one of the 12 FASD networks in Alberta. FASD stands for Fetal Alcohol Spectrum Disorder. In Alberta, I think we've got a pretty long history of lots of consultation with public on health issues and other sectors as well. Could you give us some heads up on how to ensure that these advisory groups, whether they be patient advocates, family councils, health advisory councils, how we give them some influence or power as opposed to simply taking their feedback and on paper making recommendations, but things not necessarily moving along?
That's a really good and an important question that I wouldn't pretend to have any special purchase on the correct answer, partly because I think it's very much embedded in the expectations and the roles and feelings that people have in a given community. It's imaginable that you could introduce ways of giving more formal authority, more formal approval authority to advisory groups. One of the challenges with advisory groups that get so deeply embedded in a given condition, they tend to become, if you will, lay experts in the condition, and they tend to lose connectedness with the broader public experiencing the condition. And so it's a really tricky problem of managing the relationships in a way that, that retain the right level of connectedness to the broader public. I think that a series, I don't know if there's a tradition of town hall type discussions in the province, but where you have an opportunity for people to express their ideas and their concerns and their needs in a public forum. If you have an obligation that the authorities that are making a decision will take account and respond to those questions and concerns as a part of the deliberative process, the lead to improvement, that might be another avenue of assuring that the voices are not only heard, but when appropriate, heeded and certainly considered in a more formal way. So there's some things like that that might be helpful, but in the end, I believe there's no substitute for the goodwill and open-mindedness of the leadership on both sides to be genuinely interested in the input and the ideas that come from the other. And if you have that, you've basically got it solved. If you don't have that, I don't think any of these other mechanisms really would solve the problem. No.
Thanks. Are there other, just one I had, an issue that we have, and I think from the Institute of Medicine work as well, is addressing the issue of cookbook medicine versus tailored approaches. And someone once said the biggest lie in the world and the biggest truth is that every patient is unique. But in dealing with that kind of standardization of service in clinical care, I was wondering if there was any lessons that you had of addressing individual physician autonomy versus top-down kind of approaches and guidance being enforced or voluntary, or dealing with those mechanisms to actually get better standardization of service, as you'd highlighted in the safety issue as well.
Yeah. Well, I'm glad you opened this topic, because I think it is a matter of contention in the profession about the idea that you would be forced into a cookbook of care. I don't think Scott Burke, the pilot who brought down the JetBlue aircraft, thinks that the checklist that he uses before he takes off is constraining his talent and his expertise. It's facilitating his ability to fly the plane safely and to face up to any emergency, because he knows that the basics have been covered. And in the same way, for physicians, I think we should have a standard way of approaching each patient of a given type. And our job isn't to mindlessly follow the routine. Our job is to recognize those circumstances which require the exceptional care. There's a default baseline, and the great clinician will understand exactly how each patient may deviate in some ways from that baseline and to accommodate accordingly. That's the job of expertise and the job of the clinician. But the default is still there. The baseline is still there. And the evidence is overwhelming that when you have standards and guidelines of practice, that you can, on average, produce more reliable outcomes for patients. So the key is to understand, as a clinician, your job is not mindlessly to follow this. Your job is to be able to understand when not to follow it exactly. And that's the key. Now, you mentioned the idea of physician autonomy. I'm reminded of the comment of John Kenneth Galbraith, the economist at Harvard, who said that humility is a vastly overrated virtue. And I'm reminded of that because I think physician autonomy is a vastly overrated attribute. And I think that we need, in a sense of professionalism, to move from a predominant thinking of autonomy to an understanding of responsibility. And what is the responsibility of the professional in the relationship to patients and in relationship to the larger society? And part of the conversion of professionalism is moving from autonomy to responsibility. Part is moving from a concern only for the particular patient in front of me to a concern for all patients. Part of it is understanding that you have an ongoing responsibility, first and foremost, to meet the needs of your patients. And that's the new professionalism that I think we need to have a system that will be safe, high quality, and deliver value.
Hi, Dr. Fineberg. I'm Steve Buick, also from IG. I know we don't have much time, so I'll try to be quick. When you said in the talk that all we have to do is get the physicians to change, I thought that was a laugh line, but I didn't want to be the only person laughing, because it's the essential problem, and I think we're getting to it now. And in the context of American and Canadian funding systems, as you mentioned, it strikes me that we go around and around the question of how to actually get clinical care to change, and we never seem to get quite at it. You know, the US has a market system, and so up here in Canada, we have a kind of righteous superiority, and we say, well, you know, that system doesn't work, ours must be much better. You've got something like 30% sheer waste in the system there, and so we assume our system must be different. It's probably almost as bad here. So the government fiat system doesn't seem to do much better than the market system does. We go around and around this question of how to get physicians to change. Do you think that's right, that we're missing the point, that funding systems don't do it directly, that there has to be some other way of getting at physician behavior and making their professionalism the essential value?
Yeah. I agree with the proposition of the centrality and the difficulty of change. I personally, I don't think that we've adequately tested the ways in which physicians, by their own desire, could create a system that is more conducive to the kinds of care we all want to deliver as caregivers. And if it's put into the framing of a model that enables me as a clinician to do what is right for the patient and to know where I stand relative to others and to be able to be rewarded for delivering the best quality and recognized for doing so, it starts to become a little more palatable to doctors that it can get better. The problem with change, of course, for everything almost in life is that while there's an infinite variety of possibilities of change, most of them probably do make things worse. So the trick is not just to change for change's sake. The trick is, how do you get the change among the pool of possible change that actually makes things better? That's the challenge. And so if for many of us, if you can figure out a way to do it in demonstration, so it's not everybody all at once for the entire province who has to suddenly do it differently, but we're going to establish innovation centers. We're going to find those who want to be the thought leaders and who are willing to try some things, and let's see how that works. And if it works, we'll try it a little further. And if that works in the medium adopters, maybe we can find a way to make it available to all. So I think you need to have a long-term, very persistent strategy. Change is not going to come in a flash. It's very seldom you have a case where Henry Friesen can convince the right people we need to have a Canadian Institutes for Health Research and bang, you've got it. Usually it's a lot harder. Not that it was easy, Henry, I don't mean to say it was easy, but there was a clearer path. Here you've got a lot of decision makers, you have a lot of moving parts, you have a lot of variables. So I would say the strategy would be innovation centers, trials, demonstrations, gradual expansion, and then when it's ready and it's evident, you can make the switch.
Thanks. Time for just one more question.
I'll be good, John. My name is Tricia Sizikowski, and I'm chair of the Alberta Health Industry Association. In 2003, we were contacted by a U.S. consulting firm called Suggestech. These were consultants from American Airlines, and I don't know if you're aware of the massive benefits that American Airlines accrued in the amount of dollars saved through an employee suggestion program. And I mean, we are talking here about doctors changing. That is not the problem that I see. The whole system needs to change, and we can't point a finger at one person or at one group of people, because we've all evolved together. And there's, of course, there's always the conflict between administration and the doctors. And we need to change that altogether. So I think that if we were to take the American Airlines model, get those consultants to come back to Canada and see if we could do that as a way of changing our system, because it worked. And Capitol Health at that time wasn't able to take that on board, but I think it's something that can be quite useful.
Well, I take your point. Thank you so much. I think the key in this is let's all keep our eyes open to learn from success, not just success in other countries in health or other provinces in health or other regions in health, but let's see what we can learn from other industries, from other sectors. Let's see what lessons can be adopted and applied that would lead to more effective change, that lead to safer practices, lead to higher quality outcomes. I think we've got a lot to learn, a lot to benefit from many different sources, and I hope that all of us in this great endeavor can keep this kind of open-mindedness about how we can learn and how we can improve. Thank you so very much.
Okay. Thank you very much, Dr. Fineberg, and thanks everyone for attending. And just a small token here for having here, and thank you very much. And the next health policy speaker series, I believe, is June, and I think it's the 10th. And Dame Sally Davies, who's the Chief Medical Officer for the UK NHS, will be attending, and I hope you can all join us at that time. Thanks very much.